Hello everyone, welcome to HIM 216. This will be the first in a number of lectures covering Chapter 6. We're covering Chapter 6 over a period of several weeks, and I think you'll probably have 10 to 12 lectures to listen to during that time frame. In your textbook, turn to pages 98 and 99. And you'll notice that there are a number of abbreviations and acronyms that you need to be familiar with at the beginning of this chapter. And then I would suggest that before you begin working in this chapter that you turn to page 134 and you go over the chapter glossary, so you are familiar with these terms. The root operations are included in the chapter glossary, and we are going to be going over those as a part of studying this chapter, but I think it's a good idea for you to go ahead and read these and to be familiar with them. In this chapter, we are going to be looking at the definition of a principal procedure, a significant procedure. We're going to look at the surgical hierarchy of the procedural coding system. We are going to look at the guidelines for not only assigning the procedure codes, but how we code a canceled procedure, a procedure that's converted from an open to a closed, and also coding bilateral procedures. And then we're also going to talk about the facility policy for procedure coding. UHDDS actually defines the principal procedure, and the definition is actually used by acute care hospitals, short-term hospitals, and we are reporting inpatient data elements. So it's very important for you to understand that the procedural coding system is only used for hospital inpatients. It's not used for outpatients. It's not used in physician offices. It's not used in ambulatory surgery centers. CPT, current procedural terminology, is actually used in those outpatient settings for reporting procedures. So PCS is only for hospital inpatients. And I want to, okay, so here we are in the integrated codebook. So I logged into 3M, clicked on the I-10 Red Book, and you'll recognize the alphabetical index and the tabular. Across the top, I have these different tabs, and to code in PCS, I am going to click on the Procedure tab. When I get to the Procedure tab, on the left-hand side, I have the alphabetical index, and on the right-hand side, I have the tables. Now, one thing that's very different in PCS is that you really can't code directly from the index, but you can code directly from the table. And I'll demonstrate that, and we will go over that in detail. So again, on page 99, the definition of the principal procedure is one that was performed for definitive treatment. Let's see if I have, okay, one that was performed for definitive treatment rather than diagnostic or exploratory purposes, or one that was necessary to take care of a complication. Now, your book tells you that if there are two procedures that appear to meet the definition, then that procedure that is most closely related to the principal diagnosis should be selected as the principal procedure. On the bottom of page 99, we actually have the guidelines from PCS that govern the assignment of those procedures. Hold on just a second. I apologize for this delay. I'm trying to get back to Blackboard and get it over here. Okay. Now, in Blackboard, when we go into this course, into course syllabus and information, you actually have the PCS guidelines listed here for you, the 2016 coding guidelines for ICD-10 PCS. This chapter is structured a little differently. In the other chapters, we've looked at the guidelines that have been in the very front of the chapter. In this chapter, the guidelines actually start on page 122. And so we'll have 3 lectures that basically discuss the first few chapters in this book. And then we're going to come back to page 122 and go over the guidelines first, and then begin looking at the medical surgical section. And I'm doing that because having taught this in the classroom for several years, my student feedback has been that they would like to have gone over the guidelines before we started spending a lot of time in the medical surgical section. So that's what we are going to do. So on the bottom of page 99, it tells us that these instructions should be applied when we are selecting the principal procedure. And they offer clarification on the importance of the relation of the principal diagnosis if more than one procedure is performed. And you will often find that a patient has more than one procedure. If a procedure is performed for definitive treatment of both a principal diagnosis and a secondary diagnosis, then we are going to sequence the procedure that was performed for definitive treatment most related to the principal diagnosis as that principal procedure. If a procedure was performed for definitive treatment and diagnostic procedures were performed for both the principal diagnosis and the secondary diagnosis, we are going to sequence the procedure performed for definitive treatment most related to the principal diagnosis as the principal procedure. And the third item listed here, and there are 4, it goes on to page 100. If we have a diagnostic procedure that was performed for the principal diagnosis, and a procedure is performed for definitive treatment for a secondary diagnosis, then we are going to sequence that diagnostic procedure as the principal procedure, since the procedure most related to the principal diagnosis takes precedence. And then the 4th item is no procedures performed that are related to the principal diagnosis. If there are no procedures performed that are related to the principal diagnosis, the procedure performed for definitive treatment, if there's a procedure performed for definitive treatment and diagnostic procedures were performed for secondary diagnosis, we are going to sequence the procedure performed for definitive treatment of a secondary diagnosis as the principal diagnosis, since there are no procedures, definitive or non-definitive, related to the principal diagnosis. So let's see if we can think of some examples of some of these. So for this first one, this first example, there's a procedure performed for definitive treatment of both a principal diagnosis and a secondary diagnosis. So let's say that a patient comes in and they have a fracture of the femur and a fracture of, let's say, the radius. And definitive treatments are performed for both of those. Well, the most severe of those injuries would be the fracture of the femur, so we would sequence the procedure, the principal procedure, as the reduction of the fracture of that femur. In this next example, we have procedure performed for definitive treatment, and we have a diagnostic procedure, both of them for the principal diagnosis. Now, an example of this is a patient who comes in and they have a breast biopsy and then they have a mastectomy. The biopsy is diagnostic. They're doing a breast biopsy to look at a lesion to determine whether or not the patient has cancer. That's usually why they're doing it. And the patient had cancer, so then they're doing a mastectomy. The mastectomy is considered to be the definitive procedure. The breast biopsy is the diagnostic procedure. They did the breast biopsy to figure out whether or not that lesion was cancerous. And then when it was, the definitive procedure was the mastectomy. In this next example, a diagnostic procedure was performed for the principal diagnosis. Let's say that a patient came in with a diagnosis of breast mass and they did a breast biopsy, and a procedure is performed for the definitive treatment of a secondary diagnosis. Let's say while the patient was in the hospital, they broke their hip and they had to have a hip replacement. Well, certainly the hip replacement is more significant than the breast biopsy, but the guideline says that we're going to sequence that diagnostic procedure as the principal procedure. So even though the fractured hip and the hip replacement was more significant than the mass and the negative breast biopsy, that's what gets sequenced first. And then in the next example, no procedure performed that related to the principal diagnosis. Let's say the patient comes in with pneumonia and they fall and they break their hip and they have to have a hip replacement. There's no procedure performed for that pneumonia, but there is a procedure performed for a secondary diagnosis of a fractured hip. They did a hip replacement. So we're going to have to sequence, our only option is to sequence that hip replacement as the principal procedure. It's the only option we have. It was the only one that was done. So I hope that helps clarify it a little bit. To me, it always kind of helps to put a face with the name, to put some examples with these particular guidelines. But pretty much the bottom line is, what was the principal diagnosis, and you're going to sequence the definitive procedure for that principal diagnosis first, unless there's not a principal procedure for the diagnosis. Then you just have to code what you did. Now let's talk about what a significant procedure is. Now a significant procedure means that the procedure was surgical in nature, that it carried a procedural risk, that it carries an anesthetic risk, and it requires specialized training. We do not code procedures unless they're significant procedures or unless they're a non-OR procedure that impacts reimbursement. So, is a chest x-ray surgical in nature? No. Does it carry a procedural risk? No. Anesthetic risk? No. When it says requires specialized training, it does not mean an x-ray tech or a nurse as a part of their training were trained in how to do something. It's a normal routine part of their training. Requires specialized training implies a cardiologist who receives specialized training to do heart cath, or a gastroenterologist who receives specialized training in administering anesthesia so he can do colonoscopies and EGDs. A physician that becomes a surgeon receives specialized training to perform those surgical procedures. And of course, typically they're done in an OR or in a special procedure room. Sometimes they involve anesthesia, sometimes not, but some procedures are done at the bedside and they do meet the definition of a significant procedure, and we do code them. And it tells you in your book on 100, that page 100, that a significant procedure doesn't have to be in the operating room. They perform procedures in the ER. Sometimes before a patient's admitted, they can do them at bedside, in a special treatment room. Interventional radiology, there are many procedures that are performed in interventional radiology. Sometimes you can miss these because there may not be a specific operative report. Sometimes for instance, if a procedure is done at bedside, you may find that the documentation for that procedure is in a progress note. However, usually the consent will be obtained, and sometimes you won't find an operative report, but you'll find a consent, and that's kind of your clue that maybe a procedure was done. Of course, a patient can sign a consent and then the procedure may not be done, but the presence of a consent should spur you to look for additional documentation. And of course, we always want to review the entire record before we code to make sure we have the documentation there. Now, UHDDS also requires that the date of the procedure be reported, and that the National Provider Identification Number be reported for the person who performs procedures. Typically, coders abstract these data elements at the time that they code that chart. They're in it, they're looking at it, they know who the surgeon is, they know the date of the procedure. So as part of our abstracting process, we enter that information into a very specific database, and that information is captured not only for billing, but it is also captured for maintaining our indexes, our physician indexes and our procedure indexes that we are required to maintain. So then at any point in time, we can go in and run a report by physician or surgeon and see all the procedures that they performed. We can run a report by procedure and then see all the patients that had a procedure, the physicians that completed those procedures. Now, let's talk about procedure codes that should be reported. We must report any procedure that affects payment or reimbursement. There are some non-OR procedures that do impact reimbursement, and one is a patient that is on a ventilator. They're intubated and they're placed on a ventilator. That can definitely impact reimbursement. We also want to report any procedures that are required based on your facility policy. Facilities always typically have coding policies and procedures, so you definitely want to make sure that you're familiar with what those are and report procedures according to policy. When you are coding, you want to review your procedure codes, and you want to make sure that you have a diagnosis code that corresponds to any procedure that you coded. And it would be inappropriate to say that a patient had an appendectomy when there was no code for acute appendicitis or some type of abnormality with that appendix. You wouldn't say that a patient had a colon resection without a corresponding diagnosis to justify that procedure. We want to make sure that there's medical necessity for that procedure, and that's what the diagnosis code does, is it provides you with that medical necessity. Now, CMS actually has software that is called a Medicare code editor, and actually when we look at 3M, let me get back there. When we look in let's see if any of these have MCE by them. When we look in the tabular, if something is impacted by the Medicare code editor, it actually, see where this says CHB, it says MCE. And you can actually click on that MCE and it will show you what that edit is from the Medicare code editor. And of course, when I need one, I can't actually find it. I'll probably have better luck looking at signs and symptoms. Anyway, we'll notice them as we are coding. So I'm not going to spend a whole lot of time. Here's one right here, Medicare code editor. So if I click on this, if we use, what this tells me is that if I use code R03.30.30 as a principal diagnosis, that is a questionable admission. So basically what this says is this diagnosis really does not provide medical necessity for an inpatient Medicare admission. So that's the kinds of things that the Medicare code editor will tell you. Here's another one right here, MCE. Again, it tells you that this R04.81, do you see that this is an idiopathic hemorrhage in infants over 28 days? This is the pediatric diagnosis. It is only valid for patients whose age is 0 through 17. So you wouldn't be applying this code to a 65-year-old. So that's kind of some examples of the Medicare code editor. Let's talk about a valid OR procedure. So valid OR procedures are procedures that may affect the MS-DRG, and typically they do. They may not always be performed as an inpatient. Medical necessity, from a medical necessity standpoint, those procedures may be perfectly safe if they're for a patient, if they're performed in an outpatient setting. So for instance, vaginal hysterectomy is designated as a valid OR procedure, and your textbook lists that PCS code here for you. And our book tells us that designation of a valid OR procedure doesn't mean that it has to be performed in an inpatient setting. There are many surgical procedures that can and are performed on an outpatient basis. Now, it just so happens that CMS actually has a list. It's called the Inpatient Only List. And it is a list of procedures that can only be performed if the patient is in inpatient status. Otherwise, those procedures can be performed on an outpatient basis. Some insurance companies actually do the same thing. They have very specific procedures that can only be performed as in an inpatient basis or an outpatient basis. The age of the patient is also a consideration in whether or not the procedure is safe performed on an inpatient or an outpatient basis. And also, when a valid OR, this is a non-OR procedure that affects the MS-DRG assignment. There are times that, for instance, a patient being put on ventilation can affect the DRG. And sometimes the DRG will change from a medical to a surgical DRG. And I know we haven't discussed DRGs, but this will make more sense when we actually start talking about reimbursement. And if you look on page 101 in your textbook at this first example, when we insert a totally implantable vascular device, Those are placed into patients who need long-term vascular access for different types of infusions, and examples are chemotherapy or drug administration, maybe antibiotic administration, or hemodialysis over a period of time. And sometimes these procedures will affect the DRG, sometimes they don't. When we look at this second example, a patient comes in with progressive chronic renal failure stage 5. They put in a vascular access device for dialysis. And in this particular case, when we add this procedure code to this particular diagnosis, it changes this DRG from a medical DRG to a surgical DRG. So in this instance, that insertion of the vascular access device does impact reimbursement. But in the next example, where the patient has liver cancer and they put in a vascular access device for chemotherapy, this actually groups to a medical DRG. So adding the vascular access device to this principal diagnosis code doesn't impact the DRG. Now, typically that means that there is additional reimbursement for the facility because there is a surgical procedure. And in these two examples we just looked at, in the example for the patient who has chronic renal failure, it changes it from a medical to a surgical DRG. That means the hospital will receive additional reimbursement. But in the second example we looked at for the patient with liver cancer, it does not change the DRG or impact reimbursement. And I know that you're probably saying, what on earth is she talking about? And I promise you, over time this will make more sense. I'm just trying to introduce, and your textbook is trying to introduce this little bit of reimbursement. And I want to be very clear that coding and reimbursement are two different things, but they are completely interrelated. When we're coding, just learning to code, we're not focusing on reimbursement, but we have to address it because coding drives reimbursement. It absolutely impacts reimbursement. So we'll consistently, in each chapter in your book talks about the impact of coding on reimbursement, we'll actually go through and look at examples, so we're kind of trying to address it here. There are some non-covered OR procedures that are not reimbursed by Medicare. These are things that are considered to be not medically necessary. It could be a procedure performed on an inpatient basis that should have been done on an outpatient basis. Medicare does not cover everything. An example is if a patient has plastic surgery, like if a Medicare patient has a breast augmentation, or they have a facelift, or they have their eyes done. Those aren't covered. Medicare will not pay for those procedures. They were not medically necessary. There is some limited coverage provided by Medicare. Sometimes they might be covered. The guidelines are in the Federal Registry, but we actually, in this course, not in this course, in this program, we're going to be teaching you about medical necessity and local medical review policy and national decision coverage. And you can actually go to the CMS website. You can look up a code, and CMS will tell you whether or not it will pay for it, and if it will tell you what the medical necessity has to be, and it tells you what the very often what those I-10 diagnosis codes are that provide the medical necessity for that procedure. Now, some examples of limited coverage. There are certain things that you must request approval for from Medicare, and one is a blepharoplasty or an eyelid surgery. If a patient has eyelids that droop to the point that they obstruct the patient's vision, then Medicare will actually pay for that blepharoplasty for the patient. And the physician doing the surgery actually has to request from Medicare that they will pay for it. They provide the documentation or the medical necessity, and then Medicare will come back and say, yes, we'll pay for that. On page 102 in your textbook, in this first example, this patient has cystic fibrosis in both of their lungs, and they have a bilateral lung transplant. And there are only certain facilities that Medicare approves to perform transplants. If a facility wants to perform transplants on Medicare patients and be paid for them, then they must be approved as a transplant facility. And not every facility can do transplants. There are only specific facilities that do specific types of transplants. You may have a facility that does kidney transplants, but they don't do lungs or spleen or colon or some of the other types of transplants that can be done. The surgical hierarchy determines which procedure is the most resource intensive, and then the DRG is assigned based on those procedure codes. Now, the software, this is important, the software that actually does this DRG assigning is called a grouper. And when you use this software, and when you went through your 3M tutorial, you should have seen this. When you use the grouper software, it takes the diagnosis codes, it takes the procedure codes, and it groups them to an MSDRG. And the grouper knows how to sequence the procedures. If I listed a breast biopsy, if I listed a patient with a diagnosis of breast cancer, and I listed the breast biopsy first, and then I listed the mastectomy, the grouper would regroup it, and it would put the mastectomy first and the breast biopsy second. In this first example, we have a patient has an open breast biopsy during the same episode as a simple mastectomy. The patient also has Crohn's disease. The pathology reports that the patient has breast cancer. So in this code assignment, we're going to have the code for the cancer first. That's the C50.411, and then the code for the Crohn's disease, and then the procedure codes for the biopsy and the mastectomy. And this MSDRG will be DRG 582, mastectomy for malignancy with a CC or an MCC. So in this instance, the patient was admitted, and after study it was determined that they had breast cancer. This patient also has a diagnosis of Crohn's disease, and Medicare tells us that Crohn's disease is a comorbidity, and we'll talk about complications and comorbidities in much more detail, but it is a diagnosis that impacts reimbursement. So the principal procedure is the one that was done for definitive treatment, and that's the mastectomy. Look at the next example. In this example, the breast biopsy is sequenced first and then the mastectomy. But even though the coder did that, the grouper knows to resequence it, and it still assigns the appropriate DRG 582 mastectomy for malignancy. But in this next example, the coder sequenced the Crohn's disease first. That means that Crohn's disease became the principal diagnosis code, and then they listed the code for the cancer. So the system grouped this DRG to 983, extensive OR procedure unrelated to principal diagnosis code. This particular DRG 983 These types of DRGs should always be reviewed by facilities before they are ever billed to a payer, and most payers will not pay these claims until they review the charts first, and certainly they would have detected that this was a coding error. They would have resequenced the principal diagnosis code, and they would have paid it as a DRG 582. Now that's going to conclude this lecture, and your question for this lecture is, if a nurse inserts a Foley catheter for a patient, will that meet the definition of a significant procedure? So again, the question is, nursing inserts a Foley catheter, doesn't that meet the definition of a significant procedure? Is it something that a coder would code? And that will conclude this first lecture for Chapter 6.